Welcome once again to this second part of the lecture on brainstem and cranial nerves, where in this particular second part, we are now going to focus on the cranial nerves themselves. I believe that if you've listened to the first part of the lecture, you are aware that in the first part, we looked at the characteristics, basically the morphology of the brainstem itself. And in particular, we focused on the following objectives. We looked at the functions of the brainstem. Then we dealt in depth with the external and internal morphology of each part of the brainstem, looking at the midbrain, pons, and medulla oblongata. Then we looked at the arterial blood supply to the brainstem. Those are the three that we covered in the first part of the lecture. Now, in this second part, we are just focusing on cranial nerves themselves. And the objective is to be able to name the 12 cranial nerves in order from number 1 to 12. And then for each cranial nerve, state the distribution, the function, and the effect of injury. As we talk about the distribution, because of time, we'll not be able to describe the cause and the branches of each cranial nerve. But perhaps if your level of training requires that, then it might be required of you to just go into a book again and check on the cause and branches of each of the cranial nerves. All in all, in this lecture, we'll just talk about the distribution, looking at where do these cranial nerves go to. Then yes, we'll talk about their functions, and we'll talk about the effect of injury. What happens if that cranial nerve is injured? How will the patient present? Related to the cranial nerves is what we call cranial nerve nuclei. We are going to look at what is this. We are going to talk about how we classify the nuclei. So those last two are the subject matter of this particular class. Let's start by just defining what cranial nerves are really. So cranial nerves are paired nerves which are attached to the brainstem. Now, I'm using the term brainstem sparingly because yes, there are 12, but only 10 are actually having direct attachment to the brainstem. The first two are not directly attached to the brainstem, but all in all, they're still attached to the brain, and so they're cranial nerves. Remember, nerves can be classified as either cranial or spinal. The ones that arise or attached to the brain are called cranial nerves, and the ones that are attached to the spinal cord are called spinal nerves. Remember that the spinal nerves were really many, 31 pairs of them. Cranial nerves are only 12 pairs. I've also used the term attached here again intentionally, bearing in mind that there are some cranial nerves which have motor functions, so they arise from the brainstem going out. There's some cranial nerves which are sensory, so they enter the brainstem or they enter the brain. But all in all, whether entering or leaving, they're all attached. As I've mentioned, there are 12 pairs. Conventionally, we name cranial nerves using the Roman numerals, and we name them cranial nerve number 1 up to number 12. Each cranial nerve has a name. I want us to go through those names in this particular session as we address one of the agendas that we had for this class. So the first cranial nerve is called the olfactory nerve. We don't have it in these images. The olfactory nerves usually end somewhere, and then what come out at the end in what we call the olfactory bulb. And from the olfactory bulb, what goes to the brain that we see is the olfactory tract, which is shown in this particular diagram. So that's the olfactory tract, but arising from its pathway of the first cranial nerve, which we call the olfactory nerve. The second cranial nerve is called optic nerve. These are the optic nerves, that stump and that one. The right and left optic nerve join somewhere or connect somewhere in what we call the optic chiasma. And at the chiasma, some fibers cross over and some fibers don't cross over, but all from the chiasma, we have what we call optic tract going to the brain now. In this image, it's been cut at the level of the chiasma. So we don't see the nerves, but beyond the chiasma, we see the optic tracts. The third cranial nerve is known as the oculomotor nerve. These are the oculomotor nerves. They arise from the ventral aspect of the midbrain within the interpedunculaire fossa. This is the interpedunculaire fossa because these are the cerebral peduncles. Or in this image, these are the cerebral peduncles. So this is the interpedunculaire fossa, and that's where you find the oculomotor nerve, which is the third cranial nerve. The fourth cranial nerve is known as the trochlear nerve. So this is the trochlear nerve. It also arises from the midbrain, but now a dorsal aspect. And so going around it, they'll be found on the lateral aspect of the crus cerebri, or the lateral aspect of the cerebral peduncle, as we can see there, or that one. The trochlear nerves are really unique cranial nerves compared to all the other cranial nerves on a number of ways. They are the thinnest, as you can see here. They also have the longest intracranial root, and they actually emerge from the dorsal aspect rather than from the ventral aspect, as most of the other cranial nerves do. The fifth cranial nerve is known as the trigeminal nerve. The trigeminal nerve is attached to the brainstem at the level of pons, as you can see, and the nerve actually comes out at the junction between pons and the middle cerebellar peduncle. It appears to pierce the middle cerebellar peduncle, as we can see there. The nerve has two portions. A bigger portion is a sensory portion, and the smaller portion is a motor portion. This nerve is called trigeminal because it will eventually divide into 3 divisions. So usually call those 3 divisions V1, V2, and V3. You know, V stands for 5, according to the Roman numerals. So V1 is ophthalmic division. V2 is the maxillary division, and V3 is the mandibular division. The sixth cranial nerve is known as abducens nerve. This is the abducens nerve, exiting the brainstem at the pontomedullary junction, or the pontomedullary sulcus. In particular, it exits the brainstem between the pons and the pyramids of the medulla at that point. So these are the 6 cranial nerves, abducens nerve. The 7th and 8th cranial nerves are found at the angle between pons and the cerebellum. We call that the cerebellopontine angle. Or in this image, that is the cerebellopontine angle. So the 7th nerve is this one, which we call the facial nerve. Facial nerve has 2 parts. There's that bigger part, which we call facial nerve proper. And there's that smaller portion there, which we call nervus intermedius. They both constitute the facial nerve. Next to that is the 8th cranial nerve, which we call the vestibulocochlear nerve. The vestibulocochlear nerve contains 2 nerves again within it, the cochlear division and the vestibular division. Well, the vestibular also has 2 parts, a superior and an inferior part. The 9th cranial nerve is known as glossopharyngeal nerve. The glossopharyngeal nerve arises from the medulla oblongata through the posterolateral sulcus. Remember, that is the sulcus behind the olive. If this is the olive, so the sulcus behind it. You can call it retroolivary sulcus. Next to the glossopharyngeal nerve is the 10th cranial nerve, which we call the vagus nerve. You may have heard about it some time back. Vagus nerve is also in the retroolivary sulcus, just like glossopharyngeal. And below the vagus nerve is the 11th one, which we call accessory nerve. The accessory nerve is conventionally described to have two roots, although there has been some recent debates about that concept. But let's go with what is conventional, at least for now. That the cranial nerve has two, the 11th nerve has two roots. The 11th nerve is called the accessory nerve, and it has two roots. There's a root that comes from the brain, and that is the one that qualifies to be the cranial root or the cranial accessory nerve. Perhaps that smaller one is the cranial accessory nerve. And then this other one is coming from the spinal cord, and so we prefer calling it the spinal accessory nerve. So I can say that again. The nerve we are calling accessory nerve has two roots. The cranial root, which is the one that qualifies to be called a cranial nerve, and the spinal root, which is actually a spinal nerve, which is joining the cranial root, and then the whole thing becomes the accessory nerve. That is the conventional thing, but as I told you, there has been some debates doubting that particular anatomy, but we'll not go into that detail. Remember, number 9, number 10, and number 11 are all found within the retroolivary sulcus from superior to inferior in that order. The 12th cranial nerve is this one here. We call it hypoglossal nerve. Hypoglossal nerve exits the brainstem between the pyramid and the olive. That is the anterolateral or ventrolateral sulcus. This 12th cranial nerve is called the hypoglossal nerve. So in this image, that will be the oculomotor, and that is trochlear. This is trigeminal. The 3 divisions are not shown. That is 6th nerve, abducens. This is 7th nerve, facial. That is 8th nerve, vestibulocochlear. This is the 9th nerve, glossopharyngeal. 10th nerve, vagus. 11th nerve is that tiny one there, together with this other one, constituting the accessory nerve. And the 12th one is this one here, arising between the olive and the pyramid. This is the hypoglossal nerve. So those are the 12 cranial nerves. These cranial nerves exit the cranial cavity through different foramina of the skull. That's how they come out from the cranial cavity. So they'll exit through different skull foramina. Some cranial nerves go to multiple things. Some of them just go to one thing. So a cranial nerve may have multiple distribution. For example, it might be going to the tongue, but again, it's going to, let's say, somewhere in the eye. It might be going to some muscles, but again, it's going to some skin region. So we can say that a single cranial nerve can be purely sensory, just carrying sensory function. It may also be purely motor, but it may also have a mixed cranial nerve. A mixed cranial nerve is a cranial nerve that has both sensory as well as motor functions. Let's revisit the different skull foramina where the cranial nerves will exit or enter depending on how you look at it. I'll only highlight the skull foramina that traverse cranial nerves. We have what we call the cribriform plate. The cribriform plate of the ethmoid bone is a perforated bone in the floor of the anterior cranial fossa. And this is the cribriform plate, the one labeled 1. It has multiple tiny perforations for passage of the first cranial nerve. So the cribriform plate, the holes within the cribriform plate traverse the olfactory nerve. Then we have the optic canal labeled 4. The optic canal is the path where the optic nerve will pass through. The optic nerve is the second cranial nerve. So it comes from here, going to the eye. The olfactory one was passing through here to go to the upper part of the nasal cavity. For optic, it will pass through here to go to the eye. Just below that one is what we call the superior orbital fissure, which is labeled 14 here. The superior orbital fissure is for passage of the third cranial nerve, oculomotor, fourth cranial nerve, trochlear, V1, ophthalmic division of trigeminal, and the sixth cranial nerve, abducens. Those ones pass through there. Again, they're going to the eye. Below that one is that foramen labeled 5. We call it the foramen rotundum. It means round foramen. Foramen rotundum is for the passage of V2, the maxillary division of trigeminal nerve. So that nerve passes through there to go to somewhere in the floor of the orbit. Let me use another image to show you that. It goes somewhere in the floor of the orbit. So it comes out through this particular region there, which we call the inferior orbital fissure. So we see foramen rotundum from the inside of the cranium, but from the orbit, we see the inferior orbital fissure. So the nerve passes through the whole axis. We can use this image to also revisit the superior orbital fissure, which is that one, and optic canal, which is that one. Those ones are the foramina that connect the cranial cavity to the orbit. So back to our original image, this is the rotundum, and that is superior orbital fissure, and that is optic canal. They take neurovasculature to the orbit. Behind the rotundum, posterolaterally, we have the foramen ovale, oval foramen, labeled 6 for passage of the V3 nerve, mandibular division of trigeminal nerve. So that is foramen ovale. We can also see it here. So remember, you notice we are going in order on the cranial nerves as we pick the foramina. We've already mentioned the one for number 6, which was in the superior orbital fissure. So now let's talk about the one for number 7. Label 13 here, we call that the internal auditory meatus. So the 7th nerve, facial, and the 8th nerve, vestibulocochlear, go through that foramen as they exit the brain. The vestibulocochlear, which is the 8th nerve, remains in the ear. This is the channel taking nerves to the ear. The 8th nerve remains in the ear, but the 7th nerve comes out. When it comes out through this foramen, which we call the stylomastid foramen. This is where the facial nerve comes out from, but it exited the cranial cavity through the internal auditory meatus, then come out through stylomastid foramen. Vestibulocochlear will remain in the ear. So that takes care of number 7 and number 8. The 9th, 10th, and 11th cranial nerves exit the cranial cavity through the one labeled number 12, and that is what we call the jugular foramen. So this is jugular foramen, or from this end, that is jugular foramen. For passage of the 9th, the 10th, and the 11th cranial nerve, well, the internal jugular vein also goes through that foramen as well. This is the foramen magnum. We know that the spinal cord passes through the foramen magnum, together the meninges that cover the spinal cord. But again, having mentioned that the accessory nerve has two roots, cranial and spinal root. The spinal accessory nerve goes through foramen magnum. When it comes from the spinal cord, it will go through foramen magnum to reach the cranial cavity. So understand that nerve first comes from outside to go to the cranial cavity through foramen magnum. Once inside the cranial cavity, the spinal accessory nerve join with the cranial accessory nerve. So the cranial accessory nerve is inside the cavity, the spinal accessory nerve is outside. Once the two join, now they form the accessory nerve within the cranial cavity that will now come out through the jugular foramen. Lastly, we have the hypoglossal nerve labeled 11 in this particular image for the passage of the 12th cranial nerve, the hypoglossal nerve. You can call it hypoglossal canal or hypoglossal foramen. So as I told you, I chose to pick only the foramina that are related to the passage of cranial nerves. So you don't start asking, you didn't mention this foramen and this foramen, are they important? I only chose to mention the one that carry cranial nerves so that we're able to have a defined objective. Having given you that introduction on the cranial nerves, I want us to now be able to talk about the distribution of each cranial nerve. But as we do that, we'll also be talking about the function of that cranial nerve and the effect of injury of that cranial nerve. We've already given the order of the cranial nerves. So these are the cranial nerves. Again, this image captures in a snapshot where each of the cranial nerves go. But let's do this one by one so that we have a defined way of describing them. For each cranial nerve, you need to know the number and the name, which you've already done. Then you need to know the distribution. Where does this cranial nerve go? You need to know the function. What does it do? Where it goes? And we need to know the clinical aspects. What happens if that cranial nerve is injured? How will your patient present? As I told you, we are unable to focus on some two elements of cranial nerves, which may be important depending on what you're studying. And that is the course of a cranial nerve, as well as the branches of a cranial nerve. We are unable to do that in this particular lecture, because again, that's really intense for each nerve. We won't finish if we do that. Let's start with the first cranial nerve, which we call the olfactory nerve. Told you that it passes through the cribriform plate. This is usually part of the ethmoid bone, which is on the floor of the anterior cranial fossa. The olfactory nerve is a sensory nerve. So the nerves come from the roof of the nasal cavity, and they go through the cribriform plate of ethmoid to enter the cranial cavity. From there, they synapse with what we call the olfactory bulb. And then we have second-order neurons that carry information from the olfactory bulb to the brain, which we call the olfactory tract. The role of the olfactory nerves is to carry the sense of smell from the olfactory epithelium, which is the receptor for smell in the roof of the nasal cavity. And so if you injure olfactory nerve, as it may happen in fracture of the cribriform plate of ethmoid, a patient may lose the sense of smell, what we call anosmia. The second cranial nerve is called the optic nerve. This one is also a sensory nerve coming from the eye and going through what we call the optic canal to enter the cranial cavity. The optic nerve specifically come from the retina of the eye. So not just the eye, but specifically the retina. Remember, the retina is the receptor for vision. And so we can say that optic nerve is carrying information regarding vision from the eye. You know, the eye is an organ that there could be many sensations there. Pain you can feel from the eye, even heat can be felt from the eye. But now that is not the role of optic nerve. Optic nerve carry vision. Unique thing about optic nerve is that unlike the other cranial nerves, sensory cranial nerves, which will be first order sensory neurons, optic nerve is second order sensory neuron. But let me leave it at that. You will debate that more when you look at visual pathway under sensory systems. If you injure optic nerve, what happens? The information from that eye can now not reach the brain. And so basically there'll be some level of blindness or loss of vision, what we call anopia. The third cranial nerve is called oculomotor nerve. It's a motor nerve, as the name alludes to, coming from the brainstem, specifically from midbrain, going through the superior orbital fissure to enter the orbit. The oculomotor nerve targets extraocular muscles. Most of the extraocular muscles are supplied by the oculomotor nerve. Examples of such muscles include superior rectus, medial rectus, inferior rectus, inferior oblique, and lastly, what we call the levator palpebral superioris. Those are the extraocular muscles supplied by the oculomotor nerve. The role of those muscles is to cause the eye to move, so therefore eyeball movement. That is why if oculomotor is injured, with regard to that particular role, the position of the eye may be affected. There'll be a defect in the position of the eye, and that will affect the parallelism of the visual axis of the two eyes. So if this injury occurs on one side, the visual axis of that particular eye may not be parallel with the visual axis of the other one. That's basically what we call squint or strabismus. However, oculomotor nerve does not just supply the extraocular muscles only. The extraocular muscles are skeletal muscles, so they are under voluntary control. Oculomotor nerve also supplies the muscles which are inside the eyeball. Remember, these are smooth muscles, so they are under involuntary control. The particular intraocular muscles I'm talking about here, the muscles in the iris, these are the ones that control the size of the pupil. Oculomotor causes these muscles to contract to make the pupil become narrower. So it causes pupillary constriction. And that is why if you injure these fibers of oculomotor going to the eye, then the pupil will not be able to constrict, and that's what we call pupillary dilation or mydriasis. Now, the oculomotor does not just supply the smooth muscles of the iris only, it also supplies the smooth muscles of the ciliary body. Remember, the smooth muscles of the ciliary body are still part of intraocular muscles. Those particular muscles are the ones that control the shape of the lens, which are important in focusing. And so oculomotor nerve also helps in focusing. The fourth cranial nerve, known as the trochlear nerve, also passes through the superior orbital fissure. As it goes to the orbit, it supplies one of the extraocular muscles, which we call the superior oblique, also responsible for eye movement. And so if you injure it again, there'll be a particular type of squint. The squint that a patient will get through oculomotor nerve injury is therefore different from the type of squint that a patient will get if there is trochlear nerve injury. The fifth cranial nerve, called trigeminal, because it has three divisions. V1, the ophthalmic division, exits the cranial cavity through the superior orbital fissure. V2, maxillary division, exits the cranial cavity through foramen rotundum, then inferior orbital fissure. Then mandibular division, V3, exits the cranial cavity through the foramen ovale. Whether ophthalmic, maxillary, or mandibular division, the trigeminal nerve goes to the face, or let me say comes from the face, because the sensory nerve, the sensory division was a large division we saw. So these sensory nerves come from the face and anterior scalp. Well, may also be coming from the meninges as well. What is the role of that? The purpose for that is general sensation. So things like pain, temperature, touch, vibration, proprioception sensations are relayed by the trigeminal nerve. These three nerves have their territories. The ophthalmic division, the territory is the region of the forehead. The maxillary division, the territory is between the eyes and the mouth. Then the mandibular division, the territory is the region of the mandible going down. Apart from sensory function from the face, the trigeminal nerve is also a motor nerve, which goes to muscles of the first pharyngeal arc. Now, muscles of the first pharyngeal arc are muscles that move the mandible. So we call them the muscles of mastication. Well, not all of them are attached to the mandible. So not all of them will move the mandible, but most of them move the mandible. We call them muscles of mastication. There are a few others that are still derivatives of the first arch, but they are not attached to the mandible. They are in the ear. All in all, the first pharyngeal arc muscles are supplied by the trigeminal nerve. Now, the division of trigeminal nerve that is actually motor is the mandibular division of trigeminal. So it's only the mandibular division of trigeminal that is having motor functions. The other two divisions do not have this motor function. The sixth cranial nerve is the abducens nerve. This one also exits the cranial cavity through the superior orbital fissure. It supplies one of the extraocular muscles that we call the lateral rectus muscle. And it is from that, actually, that the nerve derives its name. Lateral rectus is one of the muscles that will move the eye. And in particular, it causes the eye to abduct. That is why the nerve is called abducens. So again, the concept we've been building is that if you injure such a nerve, you'll have some degree of squinting. Again, the squinting type that we get in abducens nerve injury is different from the type of squint that you'll get in trochlear nerve injury, and different from the type of squint you'll get through oculomotor nerve injury. Seventh cranial nerve is facial nerve with very expansive distribution. Facial nerve exits the cranial cavity through the internal auditory meatus, or what we call internal acoustic meatus, to go to the ear, then comes out from the ear to the external skull through the stylomastoid foramen. This particular nerve supplies the muscles of the second pharyngeal arc. Most of the muscles of the second pharyngeal arc are on the face. They attach the skin of the face. They are responsible for facial expression. So we call them muscles of facial expression. Again, They may not all be muscles of facial expression per se, but most of them are on the face, and so they are responsible for facial expression. On that note, there's some common syndrome that we see. If there is injury of facial nerve within the ear for whatever reason, most of the time through an inflammatory process, could be due to viral infection. So the nerve is affecting the ear. When these fibers of facial nerve that go to the muscles of facial expression are affected, the muscles of that side of the face will be paralyzed. And so we usually see the mouth deviating away from the paralyzed side in what we call Bell's palsy. All right, so the other distribution of facial nerve is to the anterior 2/3 of the tongue. That has sensory function though, so maybe, let me say, fibers of facial come from the anterior 2/3 of the tongue. The fibers of facial nerve that come from the anterior 2/3 of the tongue specifically have a name. They're called the coda tympani nerve. And these branches, these fibers are responsible for taste sensation from the anterior 2/3 of the tongue. And so if these fibers are affected, then the patient will lose the sensation of taste. There's a term given to that particular concept, agousia. Apart from that, facial nerve also goes to the salivary glands. The particular salivary glands we have in mind are the submandibular salivary gland, which is just below the mandible, and the sublingual salivary gland. Well, there are also some intrinsic salivary glands. So the role for this is salivation. Again, remember that that particular role is not really a somatic function, but maybe an autonomic function. Salivation is an autonomic function. And so this will be autonomic nerves going there. Those autonomic nerve fibers are again still carried within the coda tympani nerve. Now, if you affect the branches of facial nerve that supply the salivary glands, then you'll expect that you'll affect salivation. But let me put that in a different way by also telling you another distribution of facial nerve, which is to the lacrimal gland. Again, that is autonomic. Lacrimal gland is the gland that helps in production of tears. So again, if you affect that, it means that maybe there'll be reduced tear production. But I want to combine a concept here. Having said that facial nerve goes to the salivary glands, and also it goes to the lacrimal gland. Sometimes you may have injury to facial nerve, and then by good luck, the segments of the axons which have been injured regenerate, rejoin. Unfortunately, let's say they don't rejoin accurately, so that the fibers of facial nerve, which were coming from the brainstem to go to salivary glands, now reconnect with the ones which go to the lacrimal gland. And the ones which were going to the lacrimal gland now reconnect to the ones who are going to the salivary gland. There may be some trouble. That particular individual, when they see food, instead of salivating, they'll be producing tears. And that is what we call crocodile tear syndrome. Okay, that is facial nerve. The 8th cranial nerve is known as the vestibulocochlear nerve. The vestibulocochlear nerve, just like facial nerve, exists the cranial cavity through the internal acoustic meatus. There are 2 nerves within this nerve. We have the vestibular division, or we can just call the vestibular nerve, which we have superior and inferior. And we have the cochlear nerve. The vestibular nerve goes to the vestibular apparatus of the ear. These are the structures which are used in sensing equilibrium, basically. And so therefore equilibrium sensation, equilibrium of the head. So these are sensory nerves. The fibers are going to the brain from the ear. So if you injure this nerve, then we'll expect that the patient may lose that sense of position or of the head, and that's what we call vertigo. The other division of the vestibulocochlear nerve is the cochlear nerve itself, which arises from the cochlear duct. The cochlear duct contains the receptor for hearing. The receptor for hearing is known as the spiral organ of Corti. So the cochlear duct is within the ear, and it contains the receptor for hearing, the spiral organ of Corti. So we can say, therefore, that cochlear nerve is a nerve that carries hearing sensation. And so if it's injured, you'll get hearing loss. Now, hearing loss is usually classified into two. There's what we call conduction hearing loss. And there's what we call sensory neuron hearing loss. Conduction hearing loss is the hearing loss that someone experiences if there's some wax impaction, for example, so that sound waves may not be able to pass through to the outer ear, or maybe there's some problem with the middle ear, so vibration may not pass through up to that point. Then the sensory neuron hearing loss is the hearing loss that a patient gets if there is injury to the receptor for hearing, like in this case, and the neuronal pathway that convey hearing sensation. So if cochlear nerve is injured, we'll have the sensory neuron hearing loss. The ninth cranial nerve is called glossopharyngeal nerve, exiting the brain, the cranial cavity through the jugular foramen. Glossopharyngeal nerve goes to the posterior one to the tongue, or we can say come from, because that has sensory function. Some fibers come from the posterior one of the tongue to the brain, and this is the one that mediate again taste sensation from the posterior 1/3 of the tongue. Remember, anterior 2/3 was by chorda tympanofacial nerve. Posterior 1/3 of the tongue by glossopharyngeal nerve. And so if it's injured, you lose taste sensation from that particular region of the tongue. Also, the glossopharyngeal nerve supplies the muscles of the third pharyngeal arc. The muscles of the third pharyngeal arc is particularly only one muscle. We call it the stylopharyngeus muscle. Stylopharyngeus muscle is a muscle of the pharynx. And so remember, pharyngeal muscles are important in swallowing. The other distribution of glossopharyngeal nerve is the parotid gland. This is the largest salivary gland. This large salivary gland is located just anterior to the ears. And so it's for salivation, production of saliva. And so if you injure the fibers of glossopharyngeal nerve, which go to the parotid gland, you are going to significantly affect salivation. And so the patient will be presenting most probably with a dry mouth, which we call xerostomia. Vagus nerve is a 10th cranial nerve exiting the cranial cavity through the jugular foramen. Vagus nerve supplies muscles of the 6th pharyngeal arc. Muscles of the 6th pharyngeal arc are muscles that control the larynx. So we use them for production of sound, among many other functions of the larynx, the voice box. And so if you injure the fibers of vagus nerve that go to the larynx, you're going to affect speech. The person will have difficulty in articulation. Vagus nerve also have fibers which come from the epiglottis to go to the brainstem. The fibers of vagus nerve that come from the epiglottis to go to the brainstem are supplying taste buds around the epiglottis. And so that is still for taste sensation then, except now it's not the tongue, but epiglottic region. And so that means that there'll be loss of taste sensation from that region. That might be hard to pick generally because we are not usually structured to be picking taste sensation from the epiglottis. We largely rely on the one from the tongue. Last but not least, vagus nerve go to multiple visceral organs. Multiple that we cannot even list them, but perhaps that's why vagus nerve is called vagus. From the word vague, you know, goes to multiple things. Vagus nerve goes to the heart, respiratory tree, digestive system, urinary system, and the like. Multiple organs, but they're all visceral organs. For what purpose? For parasympathetic function. So that means that again, multiple physiological effects. And so that means that if you injure it, there will be multiple clinical manifestations based on us cutting off the parasympathetic effects of vagus nerve. So it's up to you then to think through what are the parasympathetic effects of vagus nerve on the respiratory tree, on the digestive tree, on the heart, and perhaps urinary system, so that we are able to know in particular the functions. And so we are able to tell the clinical effects of injury on each organ. The 11th nerve, accessory nerve, we've said that the accessory nerve has two roots. There's the spinal accessory nerve that come from the upper 5 cervical spinal nerves, C1 to C5. Those ones climb up to go to the cranial cavity, and so they enter the cranial cavity through foramen magnum. To join with the cranial accessory root, and so the whole complex forms the accessory nerve. And then now the two come out through jugular foramen, just like glossopharyngeal and vagus nerve. The cranial root of the cranial accessory nerve go to muscles of the fourth pharyngeal arc. The muscles of the fourth pharyngeal arc are the muscles of the pharynx. These muscles are therefore important in swallowing. There are multiple pharyngeal muscles. There are those muscles which are long, they're longitudinal or rather. So you have what you call palatopharyngeus, salpingopharyngeus, and stylopharyngeus. Out of those three, the stylopharyngeus is the one that is not supplied by this because stylopharyngeus is a nerve of the third pharyngeal arc, so glossopharyngeal. But the other two, salpingopharyngeus and palatopharyngeus, are supplied by this nerve. Then we have the circular, or what we call the constrictors of the pharynx, pharyngeal constrictors, superior pharyngeal constrictor, middle pharyngeal constrictor, and inferior pharyngeal constrictor. All those are muscles of the fourth pharyngeal arch. There are also muscles of the soft palate, which are still muscles of the fourth pharyngeal arch. So all those muscles are supplied by the cranial accessory nerve. However, there's a problem. When the accessory nerve goes through the jugular foramen together with the vagus nerve and the glossopharyngeal nerve, the conventional anatomy describes that the cranial accessory root joins vagus nerve, and the spinal accessory root is the one that comes out that we see. So this cranial accessory root that joined vagus nerve now become part of vagus nerve. And so for that reason, books will tell you that the fourth pharyngeal arc muscles are still supplied by vagus nerve, and it's still okay, that is still acceptable because of what I've given you. Right now, there's some authorities that debate whether actually there is a true existence of the cranial accessory nerve. So if that be true, that it doesn't exist, then we'll basically say that fourth arc muscles are definitely supplied by vagus nerve. So that debate, we don't have to go into it. For now, we can say that the cranial accessory nerve exists, yes. And those fibers are the ones which go to the fourth arc. Although we know that from outside, we see them arising from vagus nerve because cranial accessory joined the vagus nerve. If you affect muscles for swallowing, you definitely have difficulty in swallowing. The term given is dysphagia. Now, the spinal accessory root, the one that come out that we see from jugular foramen, those fibers are directed to the trapezius muscle as well as the sternocleidomastoid muscle. Remember, trapezius is a muscle of the back as well as the neck. Sternocleidomastoid is a muscle of the neck. And so they're important for movement of the neck as well as movement of the shoulders. Trapezius particularly move the shoulders up, among other functions that it does, elevate the shoulder. The sternocleidomastoid help in rotating the neck. And so if you injure the spinal accessory nerve, these muscles are paralyzed, then there'll be difficulty in those movements. Now figure out what will be happening. The last cranial nerve, hypoglossal nerve, exists the cranial cavity through the hypoglossal canal. That's the foramen of exit of the hypoglossal nerve. It goes to most of the musculature of the tongue. Again, not all of them, because there's one that is not supplied by this. The one that's not supplied by this comes from the palate to the tongue. We call it palatoglossus. It's a muscle of the fourth pharyngeal arch. But the rest of the muscle of the tongue, whether extrinsic, which means coming from outside to attach to the tongue, or intrinsic, which means limited to the tongue, the rest are all supplied by the hypoglossal nerve. Remember, the muscle of the tongue are important for tongue movements. It could be movement, gross movement of protruding the tongue, retracting the tongue, and the like, or it could be movements of rolling the tongue. The intrinsic muscles of the tongue roll the tongue. The extrinsic muscles of the tongue make the tongue to move in those axes of coming out of the mouth, going back, and the like, going up, down, things like that. So if you injure the hypoglossal nerve and the tongue muscles are paralyzed, you realize then that a patient will have difficulty in talking. But also, if you tell them to protrude their tongue will deviate to one direction, one side. Usually, the tongue will deviate towards the side that is paralyzed. This is a bit different from facial nerve injury, where the mouth deviates away from the side that is paralyzed. For hypoglossal nerve, the tongue deviates towards the side that's paralyzed if you tell the patient to protrude the tongue. And over time, the side that is paralyzed may become thinner. So the tongue will undergo atrophy, unilateral or ipsilateral atrophy. All right, those are the 12 cranial nerves and their distribution, their function, and we've highlighted most of the clinical entities to that effect. Now, to make the story of cranial nerve be complete, perhaps you need to just practice just answering some of these questions. And I'll put a few questions here for you, just for your review. So one, I would want you to just relook at that and ask yourself, so which cranial nerves are purely sensory? And which ones are purely motor out of those 12? Also, ask yourself, which cranial nerves have parasympathetic function? There are 4. Out of these 12, which 4 cranial nerves have parasympathetic function? And perhaps name those 4 nerves and state the organs or the tissues that they're parasympathetic to, each nerve. The other question is, are you able to name the muscles that go to the eye? sorry, are you able to name the nerves that go to the eye? There are really many, we mentioned many of them. Are you able to name the nerves that go to the eye? And if you're able to, are you able to also just give the function of each nerve? The same thing you do to the eye, can we do it on the tongue as well? The nerves which go to the tongue, there are many again, and they're able to tell the functions of each. Then, depending on how deep your course requires that you understand cranial nerves, maybe the fifth question might also apply to your course. Are you able to state the origin, the cause, the distribution, and the clinical importance of the seventh cranial nerve? And I'm picking seventh cranial nerve here as just an example, but you can be asked any of them. I've just introduced the concept of cause there to stimulate you that depending on what you're doing, you might be required to know the cause of cranial nerves. And so I've just picked one nerve here to help you. Great. Now we want to do the last part of the lecture, looking at cranial nerve nuclei and their functional classification. So maybe before we talk about the functional classification, perhaps we first need to understand what are these cranial nerve nuclei. Cranial nerve nuclei are nuclei within the brainstem that give rise to the cranial nerves, or that are points of attachment of the cranial nerves. Now, understand that this nuclei can contain different categories of cell bodies, or let me put it this way. We agreed in our earlier classes that a nucleus is a collection of neuronal cell bodies within the central nervous system. So this nuclei contains cell bodies, but there are types of cell bodies of cranial nerves, which type of cell bodies of neurons that constitute the nuclei of cranial nerve. And there are three categories. One, there could be cell bodies of lower motor neurons. Lower motor neurons are neurons which go to skeletal musculature. Usually, we have what we call upper motor neuron and lower motor neuron. Upper motor neuron may arise from the cerebral cortex or somewhere in the brainstem and terminate to a lower motor neuron. A lower motor neuron is a neuron whose axon come out from the brainstem or spinal cord to go to a muscle. For example, in this image, we see a neuron coming from the cerebral cortex. That is the upper motor neuron. Come from the cerebral cortex, we see it decasseting there and going all the way to the spinal cord. This other one, we also see it coming from the cerebral to the other side, decasseting and going all the way to the spinal cord. It synapses with a lower motor neuron. And this lower motor neuron is the one that goes to the muscle. So we have a similar concept for cranial nerves as well. This one, the one that's been shown here is a spinal nerve, but same concept for cranial nerve, like what you can see here. Upper motor neurons are coming. We see decassation to synapse with the nucleus there. So this nucleus contains the cell body of the lower motor neuron that comes out. The ones that have been shown are the ones for the spinal nerves, but we'll have similar things here arising from the brainstem. Of important to note is that for the cranial nerves, we see that there is bilateral projection generally. So these upper motor neurons, which we can call corticonuclear tract, as we mentioned in the first part of the lecture, these corticonuclear fibers project bilaterally. So they go to the right and to the left. So these nuclei are the ones that contain cell bodies of the lower motor neurons that will come out to go to supply the skeletal musculature. So that is a cranial nerve motor nucleus. That is one category. Another possibility is that this cranial nerve motor nuclei, this cranial nerve nuclei may also be containing cell bodies of the preganglionic autonomic neurons. Preganglionic autonomic neurons that arise from the brainstem. Now, based on that, I want you to remember something. The autonomic division of the nervous system consists of sympathetic and parasympathetic division. The sympathetic division is for emergency responses. The nerves which subserve sympathetic function come from the spinal cord, from segment T1 up to L2 or L3, we call that a thoracolumbar outflow. These nerves excite the body under emergency situations. Then we have the parasympathetic division. Parasympathetic division arises from either a cranial nerve, and that is why we're discussing this, or a sacral nerve. So we use the term craniosacral outflow. Now, whether an outflow is thoracolumbar for sympathetic or craniosacral, as we see in this image for parasympathetic, each of these divisions consists of a relay of two neurons. There's a neuron that comes from the central nervous system to go all the way to a ganglion. And that is the one we are calling the preganglionic neuron. Then there's another one that comes from the ganglion now to the target organ. That is the one we call the postganglionic neuron. In this image, the preganglionic neurons are illustrated using red, and the postganglionic neurons are illustrated using the black line. So this is the ganglion. Remember, ganglion is a collection of cell bodies of neurons outside the central nervous system. So these are ganglion, except it's not sensory ganglion, it's an autonomic ganglion, in this case, parasympathetic. So the cell bodies of preganglionic neurons arise from the brainstem, and they are within cranial nerves. And so their cell bodies, those cell bodies form cranial nerve nuclei as well. Third category of neurons that form cranial nerve nuclei are basically the cell bodies of the second order sensory neurons. Second order sensory neurons that relay with the central process of the first order sensory neurons. Now, understand this. For sensations, usually we have a relay of three neurons. There's a neuron that will come from the sensory receptor, maybe in the skin. For example, we can take trigeminal nerve to be an example here. So we have some neurons coming from the skin of the face, going all the way to the brain. These neurons which come from, these nerves which come from the skin to go to the cranial cavity are actually dendrites. They are dendritic processes, or let me say they are peripheral processes of the sensory neurons. Remember, most sensory neurons in this regard are pseudounipolar neurons with a peripheral process and a central process. So the peripheral process usually comes out from the receptor going in as part of the nerve, then the cell body will be somewhere, forming sensory ganglion. Then the central process enters. That central process of the first order sensory neuron enters the central nervous system and synapse with the second order sensory neuron. The point of synapse of the first order sensory neuron will also be containing the cell body of the second order sensory neuron, because second order sensory neurons are basically multipolar neurons. So this point here is also considered a cranial nerve nucleus, except in this case, it's not a motor nucleus, but a sensory nucleus. So you may have motor nuclei and you may have sensory nuclei. But all in all, that's a sensory nucleus. A sensory nucleus will contain cell bodies of the second order sensory neurons. The only exception to that rule is when you talk about the mesencephalic nucleus of trigeminal. The mesencephalic nucleus of trigeminal contains the cell bodies of the first order sensory neurons. This is because the sensory nerves which carry proprioceptive information from the brain, from the head region, do not have their cell bodies within this trigeminal sensory ganglion. They are unipolar neurons. They have their cell bodies within the midbrain. That's the only exception to that rule. Otherwise, these are the categories of cell bodies that constitute the cranial nerve nuclei. There are several cranial nerve nuclei. Each cranial nerve will have a nucleus as long as it's attached to the brainstem, which means that the story we're talking about here will apply for nerve number 3 all the way to number 12. We will not talk about the nuclei of number 1 and number 2 because they're not present on the brainstem. So how do we functionally classify the cranial nerve nuclei? There are 3 levels of options that are used to classify the cranial nerve nuclei. These 3 levels of options are based on the function that the nerve fibers actually serve, the nerve fibers within that cranial nerve. And as we've seen that a particular cranial nerve may have multiple functions. If a cranial nerve has multiple functions, then expect it also to have multiple nuclei, because each nucleus tends to have a specific function. Now, the 3 levels of options are these ones, and I'll take time to explain them. The first option is we classify a cranial nerve nucleus as to whether it's general or special. After we've done that, we'll classify the nucleus as to whether it is somatic or visceral. And then the third option is we classify the cranial nerve nucleus as either afferent or efferent. And so based on these 3 options, we can have multiple combinations: general, somatic, afferent; general, visceral, afferent; general, visceral, efferent; special, somatic, afferent; special, visceral, afferent; and special, visceral, efferent. Those 7 options are there. Now let's talk about the meaning. When do we call it general and when do you call it special? When do you call it somatic? When do you call it visceral? And what makes us call it afferent or efferent? So I'll discuss them, but for the ease of understanding, I think I'll want to define first the third option before I define for you the first and the second options. So let's start with defining that third option. So the third option states that a cranial nerve nucleus can either be afferent or efferent. What do these 2 mean? The afferent function refers to a sensory function. So if this nucleus receives the central processes of the first order sensory neuron, then we call it a sensory nucleus. or an afferent nucleus. As we mentioned, that is most likely, therefore, a cell body of the second order sensory neurons in the pathway of that particular sensation. The only exception is the one for mesencephalic nucleus of trigeminal. And so when do you call it efferent? We call it efferent if it's a motor nucleus. And that means that it gives rise to neurons which go either to skeletal musculature, those are the ones we call the lower motor neurons, or it's giving rise to the preganglionic neurons that go to synapse with postganglionic neurons for the sake of autonomic function. Whether it is going to skeletal musculature or whether it's going to their preganglionic neurons, the nucleus of origin of those fibers is classified as efferent because it's a motor nucleus. So afferent means sensory and efferent means motor function. That one is straightforward. Let's now define what the term general and special really mean. It's easier for me to define special, then the rest will be called general. The special function are the functions related to the following. Functions related to the 5 special sensations. So if a nucleus is related to the pathway of the special sensations, then it's considered a special nucleus and not a general nucleus. So which are the 5 special senses? Vision, smell, taste, hearing, and vestibular function. But we've said that vision and smell, their nuclei are not in the brainstem, and so don't think about them. So now let's think about taste, hearing, and vestibular function. The neurons that carry taste sensation, the first order neurons, go synapse within nuclei within the brainstem. That nucleus will be a special nucleus. It is not a general nucleus. Similarly, applying for the nucleus for termination of the fibers of hearing, nucleus of termination for the fibers of vestibular pathway. The other category that we consider special are the nuclei that give rise to nerves which go to muscles of pharyngeal arc origin. Remember, the first pharyngeal arc, muscles of mastication. Second pharyngeal arc, facial nerve. Sorry, muscles of facial expression by facial nerve. The first one by trigeminal. Third pharyngeal arc, stylopharyngeus muscle by glossopharyngeal. Fourth pharyngeal arc, muscles of the pharynx by cranial accessory nerve. There were some debates though. Sixth pharyngeal arch, muscles of the larynx by vagus nerve. So the nuclei related to the innervation of the muscles of pharyngeal arc origin are considered special. Now you note that this one is special, but motor. The other one is special, but sensory. And so you, from what we said previously, therefore, this will be special afferent. And this other one will be special efferent for that matter. So if something does not belong to any of those 2, then we call it general. Anything that does not belong to that category is termed general. So if you know a nucleus that does not qualify to be in the pathway of a special sensation, and it's not a nucleus that's giving rise to nerves which go to muscles of pharyngeal arc origin, then that nucleus is a general nucleus. Now let's talk about when do we call it somatic and when do we call it visceral. I prefer to start with defining what visceral is. A visceral function is a function related to nerve supply to internal organs. Viscera means hidden, internal. So generally, visceral functions involve smooth muscle innervation, cardiac muscle innervation, and innervation to exocrine glands. These are visceral functions. Also, a visceral function is related to nerve supply, again, to skeletal muscles of pharyngeal arc origin. And we've highlighted what they are. So again, look at that again. If you look at the first one, where you mentioned smooth muscle, cardiac muscle, and glands, basically that means autonomic. So visceral functions are autonomic functions. And this one, we call that branchiomotor. Branchiomotor is innervation to muscles of pharyngeal arc origin. So those are the ones we call visceral. And when we call it somatic, it's easier to say the rest will now be qualified as somatic. But if you are to define that, somatic is related to body wall. And so generally, the things to do with the rest of innervation of skeletal musculature and things to do with the innervation of receptors, which are on the skin, basically belong to somatic category. So with that template in mind, we can now talk about the 7 functional categories of cranial nerve nuclei. The first one is what we call general somatic afferent function. When you talk of general somatic afferent function, it means you're talking about functions related to general sensations. In simple terms, they may be coming from the skin, they may be coming from muscles, but they're general sensations. So which nuclei in the brainstem have this function? It's a large nucleus. We call it the trigeminal sensory nucleus, or the sensory nucleus of trigeminal. This image shows you as many cranial nerve nuclei as we have in the brainstem, the nuclei that give rise to cranial nerves. And when you look at it, it might look discouraging, but let's just break it down slowly and you'll understand it's not a difficult thing. So the GSA nucleus is the sensory nucleus of trigeminal. It's a long nucleus, as we can see in this image, very long. It means the point of synapse of the first order sensory neurons going in, apart from the one we see on the upper part though. Anyway, this sensory nucleus of trigeminal has 3 parts. The part that is within the midbrain, the part I'm pointing, is called the mesencephalic nucleus of trigeminal. This one is the one that receives the proprioceptive fibers from the head region. The part within pons is called the principal nucleus, the principal sensory nucleus of trigeminal, or the chief sensory nucleus of trigeminal. You can call it the main sensory nucleus of trigeminal. This one has touch functions. So the fibers for touch terminate there, touch from the head region. Then there's this part that spans all the way to this medulla oblongata and even upper part of the spinal cord. We call it the spinal nucleus of trigeminal. The spinal nucleus of trigeminal serve pain and temperature sensation. So neurons which carry pain and temperature, the first order neurons synapse there, then second order neurons pick from there to go to the brain or to go to the thalamus, basically. So the GSA nucleus within the brainstem is the trigeminal sensory nucleus. Now, something to note, the neurons that synapse here don't have to actually have been carried through the trigeminal nerve itself. Even if these fibers came through facial nerve, but it's for general sensations from the head region, they'll synapse in the sensory nucleus of trigeminal. Even if these neurons were carried through glossopharyngeal nerve, as long as it is for general sensation from the head region, they'll synapse to any of these respective according to the function. So understand the trigeminal sensory nucleus is the only GSA nucleus on the brainstem. And so any nerve can terminate into it as long as it has a GSA function. The second functional category is GSE, simply mean nerve supply to skeletal musculature. Other than the muscles which arise from pharyngeal arc. And so which nuclei have GSE function? The motor nucleus of oculomotor located within the midbrain goes to extraocular muscles. Or rather, the nerve fibers from there go to extraocular muscles. The trochlear nucleus, again within midbrain, the fibers from there go to superior oblique. Abducens nucleus within pons, the fibers from there go to lateral rectus. And lastly, hypoglossal nucleus within the medulla oblongata. So this is the hypoglossal nucleus within the medulla oblongata. The fibers from there carry lower motor neurons, which go to the muscles of the tongue. So these are GSE nuclei, cranial nerve nuclei with GSE function, those four. Third category, we have GVA, general visceral afferent. When you talk of GVA, we are talking about autonomic sensations, those sensations that don't reach your perception, but they're still important. And in particular here, we're talking about sensations from the baroreceptors within the blood vessels and chemoreceptors again within blood vessels. Those are general visceral afferent sensations. These sensations are largely carried through vagus nerve as well as glossopharyngeal nerve. So which nucleus has this role in the brainstem? We have what you call the nucleus of the solitary tract, nucleus of the tractus solitarius, or nucleus of the solitary tract. It is predominantly within the medulla oblongata. That nucleus is predominantly within the medulla oblongata. So it receives visceral sensory afferents, neurons from baroreceptors and chemoreceptors synapse there. Fourth category, GVE, general visceral efferent. When you talk of general visceral efferent, we are talking about an autonomic outflow. And because we're talking about cranial nerves here, that simply means parasympathetic outflow. Outflow that is parasympathetic in function. So that means it involves nerve supply to smooth muscle, cardiac muscle, and glands. We can classify these functions this way. There's what we call secretomotor function. Secretomotor function refer to functions which go to exocrine glands. For example, innervation to lacrimal gland or salivary gland or sweat glands. Although the one to sweat glands is not parasympathetic, that one is sympathetic, so it's not from cranial nerve. The term secretomotor means innervation to exocrine glands for secretion, Then visceral motor refers to innervation to visceral organs, basically, like heart, respiratory tree, stomach, esophagus, and the like. There's also another entity that is not here because it is for the sympathetic division, and sympathetic don't come from the brainstem, but we call it vasomotor. Vasomotor refers to innervation to smooth muscles on the blood vessels. Vasomotor. So visceral motor, secretomotor, and vasomotor are autonomic functions, except that vasomotor is not part of the efferents that will be parasympathetic. Now, which nuclei have GVE function from the brainstem? Edinger-Westphal, located within the midbrain, give you the preganglionic parasympathetic fibers within the oculomotor nerve, the ones that go to the eye. So the synapse somewhere, the ganglion the synapse in is called the ciliary ganglion, before the synapse, the postganglionic neurons that go to the eye. Superior salivatory nucleus is located at the junction between the pons and the medulla. The superior salivatory nucleus contains the preganglionic parasympathetic fibers within facial nerve. So the fibers here go to facial nerve. Now, the nucleus, superior salivatory nucleus, is therefore for innervation of salivary glands, submandibular and sublingual, or even the intrinsic ones. The upper part of the nucleus, the upper part of the superior salivatory nucleus contain fibers which go to the lacrimal gland. And for that reason, some people give that a particular name. Some people call that the lacrimatory nucleus. So if that be it, then you need to add to this list the lacrimatory nucleus as well. The lacrimatory nucleus is a general visceral efferent nucleus of facial nerve that contain preganglionic fibers which go to the lacrimal gland. Then the rest of the superior salivatory nucleus contain the cell bodies of preganglionic neurons of facial nerve which go to the submandibular and sublingual gland, the ones that will be carried through chorda tympani. Inferior salivatory nucleus contain the cell bodies of the preganglionic neurons that are contained within glossopharyngeal nerve, the ones that go to the parotid gland. And lastly, we have the dorsal vagal nucleus. The dorsal vagal nucleus, also called the motor nucleus of vagus. It contains the preganglionic parasympathetic neurons within vagus nerve, the one that go to multiple organs: heart, respiratory tree, digestive tree, urinary tree, and the like. So the dorsal vagal nucleus is located within the medulla. The salivatory nuclei are located at the pontomedullary junction. Edinger-Westphal is located within the midbrain. Remember the concept of lacrimatory nucleus, the upper part of superior salivatory nucleus. Now, we've talked about 4 functional categories so far: GSA, GSE, GVA, and GVE. Those 4 are present both in cranial nerves as well as in spinal nerves. So even a spinal nerve may have a GSA, a GSE, a GVA, or a GVE. Remember, the GVE nucleus of the spinal cord will be the lateral horn of the spinal cord, or what we call the lamina 7, which is present only on the thoracic to upper lumbar or the 3 middle sacral segments. Thoracolumbar for sympathetic and sacral for parasympathetic. So these 4 are present in cranial nerves as well as spinal nerves. But the other 3 we are going to talk about are only present on cranial nerves. We don't have them on spinal nerves. Let's mention them. We have SVA, special visceral afferent. Special visceral afferent simply refers to taste, and the nucleus that relay taste is called the gustatory nucleus. Interestingly, it is considered to be the upper part of the nucleus of the solitary tract. In that case, therefore, we can still say that the nucleus of the solitary tract is still a special visceral afferent nucleus. But if you choose to distinguish that separately, then it's okay. Call it gustatory nucleus for special visceral afferent, and the other part, solitary nucleus, as the GVA nucleus. Otherwise, the common concept is that the nucleus of the solitary tract is a visceral afferent nucleus. So this is the nucleus, yes. The upper part of it is considered to be the gustatory nucleus. Then the rest of it is considered to be the one for general visceral afferent. So that this is special visceral afferent and this is general visceral afferent function. So the nerve fibers that will synapse here will be the one carried through facial nerve from the anterior 2/3 of the tongue, glossopharyngeal from posterior 1/3 of the tongue, and vagus nerve from the taste buds around the epiglottis. The 6th one, SVE, special visceral efferent function, refers to branchiomotor function. This is innervation to skeletal muscles of pharyngeal arc origin. The nuclei that will have this role are these ones. We have the motor nucleus of trigeminal. Located within pons, it gives rise to the lower motor neurons that supply muscles of the first pharyngeal arc. Motor nucleus of facial, also located within pons, it gives rise to lower motor neurons that supply muscles of the second pharyngeal arc. Then we have nucleus ambiguous, located within the medulla. Nucleus ambiguous give rise to lower motor neurons contained within glossopharyngeal for the 3rd pharyngeal arc, vagus for the 6th pharyngeal arc, and cranial accessory for the 4th pharyngeal arc. Now you understand why that nucleus is called nucleus ambiguous, because it gives rise to 3 cranial nerves. It supplies 3 pharyngeal arches via 3 cranial nerves, yet just 1 nucleus. That's the nucleus ambiguous. The last one, special somatic afferent. Special somatic afferent refers to auditory and vestibular functions. The nuclei will therefore be the cochlear nuclei related to cochlear pathway and vestibular nuclear complex. The vestibular nuclei are multiple, so we talk of the vestibular nuclear complex. The cochlear nuclei are 2, but the vestibular nuclei are about 5. Those ones are special somatic afferent. We have those 7 functional classification of cranial nerve nuclei. You notice that we don't have special somatic efferent. So don't add it. We don't have it. Good. Now, your duty is then to figure out from what we talked about earlier about cranial nerves and where they go, Now you need to go back to that template and fill in each of those functions. If you say the facial nerve goes to lacrimal gland for salivation, how do you classify that? And so which nucleus is that? If facial nerve goes to the anterior tooth of the tongue for taste, how do you classify that? And so which nucleus will that be? So that a cranial nerve will have as many nuclei as the functions it serves. Good, so this is just in summary. Sorry, the table might not be so clear, but this is the best I got. That's just in summary where the different nuclei, their particular functions. I've chosen to use a different naming system there so that you integrate what you've said with what we have right now. All right, go through that table again. Notice that, let's, for example, take the general sensory function. I told you that the only nucleus within the brainstem for general sensation is the sensory nucleus of trigeminal. If in the midbrain, you call it mesencephalic nucleus. In the pons, you call it the principal nucleus. And in the medulla, we call the spinal nucleus, irrespective of the cranial nerve that will terminate into it. So if you are asked to name the nuclei related to a particular cranial nerve, you don't just mention the one that bears its name. If it has general sensory function, you may have to also to mention the sensory nucleus of trigeminal. It is in as much as trigeminal is not that nerve. All right, so that's the story. Look at that, and I hope you've understood the functional classification of cranial nerves. So this lecture, we looked at the names of the cranial nerves, 12 of them in order. We looked at the distribution, the function, and clinical effects of some of them, or most of them. We've also looked at the cranial nerve nuclei and how we classify them, and I hope you've understood. So that will mark the end, therefore, of this lecture, that very long lecture on brainstem and cranial nerve. We divided into two parts for the sake of delivery, and I think you now understand why we had to do that. Thank you very much. We'll stop there.